Good morning, respected teachers and dear friends. Today I will be presenting on the topic compressive myelopathy, and the moderator for the presentation is Dr. Divya Madam. We will be covering the topic under these headlines: neuroanatomical localization covering spinal cord, cross-section of spinal cord, blood supply, whether it is a compressive or non-compressive lesion, extramedullary versus intramedullary lesion, cornus cauda, etiologies and cases. So the presence of a horizontally defined level below which a sensory, motor and autonomic function is impaired is a hallmark of a spinal cord disorder. So we'll be seeing under 5-step approach whether the symptoms and signs suggesting the disease in spinal cord, what are the longitudinal structures that are involved, and what is a cross-sectional level of involvement, the sensory level, motor level, autonomic and reflex level. Is it a compressive or a non-compressive myelopathy? Are there any other neural structures involved? So spinal cord extend from the lower part of medulla up to the coccygeal region. So there are 31 pairs of spinal nerves, which includes 8 cervical, 12 thoracic, 5 lumbar, 5 sacral and 1 coccygeal. And the C1 to C7 nerve roots exit above the vertebrae. From C8, the nerves exit below the vertebrae. So there is a discrepancy exists between the spinal segments and the vertebral level. The upper cervical will be at the same level. The lower cervical will be spinal segment will be one level higher to the corresponding vertebral body. So for upper thoracic, adding 2 and from D7 to D9 adding 3 to the vertebral layer will give the corresponding spinal segment level. And D10 vertebrae corresponds to L1 and L2, and D11 corresponds to L3 and L4, and D12 corresponds to L5, and L1 corresponds to sacral and coccygeal segments. Spinal cord has organized into gray matter and white matter. The central butterfly-shaped region or the H-shaped region containing neuronal cell bodies. It has a dorsal horn which receives sensory input. Ventral horn, it has lower motor neurons for skeletal muscles, and the lateral horn which has the thoracic autonomic neurons. And in the white matter, it has peripheral columns. These are peripheral columns containing ascending and descending tracts. And the posterior column or the dorsal column medial lemniscal pathway for the joint position and vibration, and the lateral column contains motor and mixed tract, and the anterior column contains motor and spinothalamic tract. So in the ascending tract, the important one are the spinothalamic tract, which relays pain and temperature and crude touch, which is in the anterolateral system in the spinal cord. And the posterior column has or the dorsal column that relays a vibration and proprioception and the light touch. So and other ascending tracts include anterior spinothalamic tract, which relays light touch and pressure to the posterior central gyrus, and the other one is spinocerebellar tracts, which carries unconscious proprioception. Now the descending tracts, the important one is the corticospinal tract, which has localizing value in myelopathy. The corticospinal tract, it decussates at the anterior part of the medulla, then it crosses over to form the lateral corticospinal tract, and the uncrossed fibers will form the anterior corticospinal tract. And the other tracts are vestibulospinal tract, tectospinal, lubrospinal tract. These are no localizing value, but they modulate the motor activity to facilitate the fine movement of limb muscles. These are the tracts: corticospinal, reticulospinal tract, tectospinal tract, rubrospinal tract, vestibulospinal tract, and olivospinal tract. Now we'll see the somatotopic organization of the tracts. So in the white matter, we have the spinothalamic tract and the corticospinal tract. In both these tracts, the lamination or the arrangement is the cervical fibers are placed medially and the sacral fibers are placed laterally. Whereas in the posterior column, the cervical fibers are arranged laterally and the sacral fibers are arranged medially. Similar to in the white matter, in the gray matter also, in the dorsal horn, we know it is for the sensory function, And the ventral lobe contains motor neurons, gamma motor neurons, alpha motor neurons, and interneurons, which helps in fine tuning of movements of effector muscles. Here also, the motor nuclei has lamination. The motor nuclei of axial and proximal muscles are medially placed. The distal muscles are laterally placed. The flexor muscles are more dorsally placed, and the extensor muscles are ventrally placed. And the myotomes and dermatomes, we know C5 for shoulder abduction, C6 for elbow flexion, C7 elbow extension, C8 T1 for intrinsic hand muscles. In the lower limb, L2 for hip, L1 L2 for hip flexion, L3 L4 for knee extension, L4 angle dorsiflexion, L5 great toe extension, S1 for angle plantar flexion, and S1 for knee flexion. And the dermatomes is a region of a skin or a structure which has a somatic afferent sensory innervation provided by single spinal cord segment and a single nerve root. So this region is a cervical dermatome, this is thoracic dermatome, and the lumbar dermatome and the sacral dermatome. Now coming to the blood supply, spinal cord is supplied by anterior spinal artery and paired posterior spinal artery which arise from the vertebral artery. Anterior spinal artery supplies a anterior 2/3 and posterior supplies a posterior 1/3. And 6 to 10 radiculomedullary vessels that reinforce the anterior spinal artery, and 10 to 20 radiculomedullary arteries reinforce the posterior spinal artery. The largest radicular artery is the artery of Adam Kiewicz, which is important mainly in the thoracic and lumbar region, which can be damaged during the surgery on aorta also. And we have watershed areas also. In the cervical cord, T1 and lumbosacral, they have a good feeder supply, whereas thoracic cord has got just a single feeder, the poorest arterial supply, and it is more vulnerable to ischemia. So the area between upper and mid thoracic and between the lower thoracic and upper lumbar segments, these are watershed areas. And in a cord compression, the most vulnerable tracts are corticospinal, followed by posterior column, and finally the spinothalamic tract due to ischemia. So first we'll see the cross-sectional spinal cord localization or the cord syndromes. Here first each we will see in detail. Complete cord syndrome is a complete transection of the spinal cord where there is horizontal involvement of the spinal cord. The features will be, there will be total permanent loss of all motor, sensory and autonomic function below the level of injury. So bilateral UMN pattern weakness below the level, bilateral sensory loss including pain, temperature, vibration and joint position below the level, and autonomic function below the level. And the most common etiologies are trauma, acute complete transverse myelitis, hemorrhage, abscess, metastasis. Then yes sir. Hemorrhage, epidural abscess, metastasis, necrotizing myelopathy and late radiation induced myelopathy. Next is Brown-Sequard syndrome. Here only one half of the cord is involved. Both ventral and dorsal part is involved. The features will be, there will be ipsilateral on the same side as the corticospinal tract is involved, UMN pattern of weakness below the level, and at the level on the ipsilateral same side LMN pattern weakness. On the same side, ipsilateral, due to posterior column involvement, ipsilateral vibration and joint position is involved, and contralateral pain and temperature sensation below the level as the spinothalamic tract crossing over occurs within the cord. And the etiologies are most common penetrating traumas, multiple sclerosis, asymmetric compression. Now coming to the central cord syndrome, here the lesion starts from the central part of the cord. Early cases, that is in small lesion, only the decussating spinothalamic fibers are affected. So the patient will be presenting with suspended sensory loss. Mainly pain and temperature will be lost in a classic cape-like distribution that mainly affect the shoulder, arms and trunk. In late and large lesion that started affecting more anteriorly, yes.
That's when you just like the fibers and
So in the initial stage, that is in the early small lesion, these decussating fibers crossing through the anterior white commissure will be affected. So suspended sensory loss with the classic loss of pain and temperature in a cape-like distribution, that is mainly affecting the shoulders, arms, and the trunk will be affected. Whereas in case of large and late lesion, this will start expanding and it start affecting the anterior horn cells in the ventral part of the cord. So along with spinothalamic tract, motor neuron fibers are also affected, and there will be additional segmental element pattern of weakness at the level will be there. The classic condition we'll discuss is syringomyelia. Here the clinical features will be upper motor neuron pattern of weakness below the level, predominantly upper limb is involved than lower limb, and a long segment element pattern of weakness due to the anterior horn cell involvement in bilateral upper limb, and sacral sparing will be there because in spinothalamic tract, as we discussed in the lamination, the sacral fibers are placed more laterally, and there will be a segmental dissociative sensory loss because here only spinothalamic tract is involved in the early and the posterior column fibers are preserved. So patchy segmented dissociative sensory loss will be there, and other conditions are intramedullary tumor and NMO spectrum disorders. It extend all sides. Yes, yes, ma'am. In the early stages, it will be posterior column will be preserved. In late stages, as it expands, it affects the dorsal column also, and it can involve the joint position and vibration sense also. Then the posterior cord syndrome, it affects mainly the posterior column. Here, clinical features, they will present with loss of vibration and joint position sense below the level, and the reflex will be normal. They will present with sensory ataxia and Lermit sign if it is in the cervical region, predominantly seen in cervical spondylotic myelopathy and multiple sclerosis. They will have when the sudden flexion of the neck will cause severe shooting pain down bilateral upper limb to legs. The common etiologies are tabes dorsalis, posterior spinal artery infarction, radiation-induced myelopathy. Then, sir, that is cervical spondylotic myelopathy and multiple sclerosis. Then anterior cord syndrome, where ventral and lateral part of the cord is involved, sparing the posterior column. So they will present with bilateral element pattern of weakness at the level, bilateral UMN pattern of weakness below the level. There will be bilateral pain and temperature sensation loss below the level, and autonomic function loss also below the level as the lateral columns are involved, and bilateral vibration and joint position sense will be preserved. Etiologies: anterior spinal artery infarction, poliovirus infection, West Nile virus infection. Then next is the posterolateral syndrome, where both posterior and the lateral corticospinal tract are involved. They present with bilateral vibration and joint position loss below the level, and bilateral UMN pattern of weakness below the level. They can also present with sensory ataxia and spastic gait. The etiologies commonly mentioned are vitamin B12 deficiency, copper deficiency, cervical spondylotic myelopathy, HTLV associated myelopathy or tropical spastic paraparesis, hereditary spastic paraparesis, HIV, and paraneoplastic myelitis. Then coming to anterior horn syndrome, here the ventral part of the gray matter is affected that contains anterior horn cell. Clinically, they present with diffuse element pattern of weakness with hyporeflexia, fasciculation, and wasting. Etiologies described are poliovirus, West Nile virus infection, spinomuscular atrophy, spinobulbomuscular atrophy. Then next is a combined anterior horn and corticospinal disease. Here there is a combined UMN pattern weakness and element pattern weakness. In addition, there will be bulbar weakness, and this will be a pure motor syndrome. The classic example is amyotrophic lateral sclerosis. So these are the spinal cord syndrome which we discussed now. after seeing the cross-sectional spinal cord localization, now we'll see the longitudinal cord localization. Here we will determine at which level the lesion is. So whether it is a foramen magnum or at upper cervical, lower cervical or upper thoracic, lumbosacral, conus medullaris or cauda equina level. So in foramen magnum syndrome, uh, the hallmark feature is crural paresis because a lesion in the foramen magnum, it interrupts the decussating pyramidal tract fibers for the legs. These legs fibers, they cross more caudally to than that of arms, so they will have predominant lower limb weakness. And they will have this around the clock pattern or the Ellsberg phenomenon, where compressive lesions near foramen magnum or upper cervical will cause weakness of the ipsilateral shoulder and arm, followed by weakness of ipsilateral leg, then contralateral leg, and then contralateral arm. So this is also known as a U pattern of weakness, which may begin in any of the four limbs. And in foramen magnum syndrome, they may also present with suboccipital pain that spreads to neck and shoulder and downbeat nystagmus and cerebellar ataxia. So the other levels at cervical level, because the trigeminal sensory nucleus, as it extends down below C1, C2, C3, so they can have onion peel sensory distribution in foramen magnum syndrome. At C5, C6 level, they can have at the level LMN weakness and below UMN weakness. C7 inverted triceps reflex, and hand atrophy is explained as a false localizing sign because of the venous compromise affecting extending down to C8, T1, and diaphragmatic dysfunction occurs with the C3, C4, C5 level involvement. At thoracic level, the classic signs are Beaver's sign, Horner syndrome at C8, T1 level, intercostal neuralgia, and orthostatic signs and symptoms above the T5 level. And at lumbar level, false localizing sign due to cordus cona involvement. Cordus cona we will be seeing later. And in conus, epiconus, the segments are L4, L5, S1 and S2. And conus, S3, S4, S5 and coccygeal segment. And cauda equina are all roots below the L2 comes under cauda equina. So in conus medullaris, the spinal cord ends in adults at lower border of L1, and we know the function is parasympathetic output for bladder and bowel, and also the pudendal output for the innervation of sphincters and the perineal muscles. So clinical features, they will have early bladder dysfunction. It's an LMN type of bladder, bilateral saddle sensory loss, absent anal and bulbocavernous reflex, and weakness of anal and external urethral sphincter, but they does not cause any weakness or sensory abnormality in the lower limb. The etiology mainly mentioned are lumbar disc disease, conus myelitis in Moog, and trauma, ependymoma, epidural metastasis or epidural abscess, CME infection, schistosomiasis. And in cauda equina lesion, it mainly causes asymmetric atrophic areflexic paralysis of the lower limb, and there will be pain and paresthesia of lower limb with late involvement of bladder, as well as combined conus and cauda lesions can also occur. So we'll see how to differentiate between this conus medullaris and cauda equina lesion. Pain, first if we see pain, it is more prominent, severe and radicular asymmetric type of pain is seen with cauda equina, whereas pain is not that prominent and symmetric pattern of involvement in conus medullaris. Sensory changes are also symmetric with dissociated sensory losses seen with conus medullaris, which is asymmetric saddle anesthesia pattern with no dissociated sensory losses seen in cauda equina. The motor loss also, it will be symmetric, which is not that much marked with external sphincter weakness is seen in conus medullaris, whereas asymmetric marked weakness with atrophy, paraparesis and LMN weakness due to root involvement is seen with the cauda equina. In reflexes, mainly the bulbocavernous and anal reflex will be absent and angle jerk will be absent in conus medullaris. And in cauda equina, angle and knee jerk will be diminished or absent. Bowel bladder involvement will be early in conus medullaris lesions, whereas which is less in cauda equina lesion. Sexual dysfunction also early seen with conus medullaris, and asymmetric paraparesis seen with the cauda equina lesion. So now after seeing this longitudinal also, now we'll see the transverse localization. In transverse localization, we'll mainly see the motor level, that is a segmental element with the UMN below, and the sensory level based on pain, temperature, and vibration. Reflexes at inverted reflex or reflexes will be absent at the level, and below the reflexes are exaggerated. Then based on superficial reflexes and special signs. So sensory level mainly pain and temperature. Usually the lesion is 1 to 2 segments higher due to the fiber crossing. As we know, spinothalamic tract fibers crosses 1 to 2 levels higher. Then motor tracts will present with paraplegia or quadriplegia, hyperreflexia, Babin, extensor plantar response, and spasticity. Autonomic, they will have bowel bladder and sexual dysfunction. And in spinal shock, in acute transverse lesion, they will have flaccid paralysis, areflexia, later spasticity. So segmental signs bi-level cervical lesion, usually they will present with quadriplegia, diaphragm weakness, and Horner syndrome. C5, C6 usually biceps weakness. C7 will have finger or wrist extensor weakness and triceps involvement. C8 will have finger wrist flexion involvement. At thoracic sensory level, nipple is at T4 level and umbilicus is at T10 level. And T9, T10, we will have the beaver sign due to the weakness of the lower abdomen. The when the upper abdomen contracts, the umbilicus will go up. And at lumbar level, L2, L3, L4, there will be weakness of thigh flexion, adduction, knee extension, and reduced or absent patellar knee jerk. And L5, S1, foot angle movements are reduced and knee flexion will be reduced and angle jerk will be absent. And conus cauda, as we discussed, there will be in conus there will be saddle anesthesia, early bladder bowel sexual dysfunction, and in cauda equina they will have asymmetric radicular pain and weakness, areflexia, and bowel bladder is less affected. So now we will see whether this myelopathy is it a compressive or a non-compressive myelopathy, and in compressive whether it is extramedullary or intramedullary. So to differentiate between compressive and non-compressive, in compressive mainly we know they will have root pain, asymmetric involvement of limbs, with usually there will be a sensory level, and at the level there will be a zone of hyperesthesia with a bony deformity, bony tenderness, a girdle-like sensation, and in case of intramedullary compression there will be early bowel bladder involvement. Coming to compressive myelopathy, compression of the spinal cord causing neurological deficits. These are classified by the anatomical location of the compressing lesion. So we'll divide them into three main compartments: intramedullary, in extramedullary, extradural, and intradural. And the presentation depends on the level, rate of onset, and the compartment. And the common causes: spondylosis, disc prolapse, tumor, infections, and vascular lesions. So the clinical clues are radicular and vertebral pain, early UMN signs, and rare element signs. That element signs will be at the level of compression. Ascending paresthesias as the sacral fibers are more laterally placed, and a brown sequoia-like pattern with local deformities. So in the once localized it as a compressive lesion, then we have to find whether it is extramedullary or intramedullary, and in extramedullary further extradural or intradural. So extradural lesions are either from degenerative vertebra or metastasis, which compress the dura and spinal cord. Major causes are tumor and trauma. Extradural neoplasms are more aggressive malignancies, metastasis, whereas intradural neoplasms are more of an indolent tumors, meningiomas, or neurofibromas. The classic examples given under each of this are: in extradural compression, we have spondylosis, disc prolapse, trauma, metastasis, tubercular port spine, epidural abscess, epidural hematoma. In intradural extramedullary, we will have neurofibromas and meningiomas, lipomas or sarcomas, arachnoiditis, sarcoidosis, AV malformations, leukemic infiltration, arachnoid cyst, cervical meningitis, or even metastasis can also occur. Intramedullary lesion, the most classic example we'll discuss is syrinx, then ependymoma, astrocytoma, hemangioblastoma, and hematomylia. So we'll see how to differentiate between an extramedullary and intramedullary lesion. Extramedullary lesion, they will have the classic radicular type of pain, and this is an early symptom, whereas in intramedullary, it is more of a tract pain or a funicular pain, which is a burning kind of pain. And the sensory loss here in extramedullary, they will have contralateral side loss of pain and temperature, and ipsilateral side loss of joint position and vibration. So the brown sequoia pattern. And in intramedullary lesion, as the lesion is expanding outside, there will be a dissociation of sensation with patchy distribution. And saddle anesthesia also, it is more marked at the level of lesion in extramedullary and is less marked in intramedullary lesion. And the element involvement is segmental involvement in extramedullary, whereas a widespread with atrophy and fasciculation with multiple segment involvement due to anterior horn cell involvement seen in intramedullary lesion. UMN involvement is prominent and early in extramedullary lesion, which is late and minimal in intramedullary lesion. And as well as the reflexes are also brisk and increased in extramedullary, which is late and minimal in intramedullary lesion. There will be early bladder bowel involvement in intramedullary lesions, and the trophic changes are more marked in intramedullary lesion due to the decussation of spinothalamic tract. Here, as if we compare all the three, we can see that usually intramedullary lesions and intradural extramedullary lesions are asymmetrical, whereas extradural is more of symmetrical. And the progression is also rapid with more common, root pain is more common. And as we discussed, fasciculations, element involvement, all these are more common, muscle atrophy, all common with the intramedullary lesion. And coming to the sensation, joint position sense is lost early in extradural as it is compressing from outside, and it is preserved or spared in intramedullary. And pain and temperature sensation lost early in intramedullary as it is expanding from the center to outside. The spinothalamic crossing fibers are involved, and lost late in extradural. Dissociative sensory loss and early bowel bladder involvement in intramedullary, and bony abnormalities are most commonly seen with extradural. So if we see intramedullary lesion, they will have a descending level as the intramedullary trunk, then lower limb in a sequential manner will be involved. And this in spinothalamic tract, as the sacral fibers are placed more laterally, the sacral segments affected last and perianal area is usually spared. So there will be sacral sparing will be seen. And a suspended dissociated sensory loss that we discussed earlier, area of loss of pain and temperature, few dermatomes with normal sensation above and below, and the lesion affecting central cord will, as a lesion, it disrupt the crossing fibers. And early bowel bladder involvement, because of the descending bladder fibers, these are more medially placed in the lateral funiculus. And severe sensory and motor deficit in upper limb, and the upper limb fibers are medially placed in corticospinal tract and spinothalamic tract. So we'll see some of the cases. A 62-year-old manual laborer with no definite history of trauma, he presented with progressive neurological symptom for last 8 months. History of chronic neck pain radiating to both shoulders, worsened on neck movement, with progressive weakness and clumsiness in both hands, numbness and tingling sensation in both upper limb and lower limb, and difficulty in walking with stiffness and imbalance, with a recent history of urinary urgency and occasional incontinence for past 1 month. On examination, his tone was increased. There was spasticity in all 4 limbs, and his upper limb power was 4 by 5 with intrinsic hand muscle weakness. Lower limb power was 4 by 5 with brisk deep tendon reflex in upper limb and lower limb. And Hoffman sign was positive, sustained angle clonus and bilateral extensor plantar. And sensory, there is a glove and stocking distribution of sensory loss with an impaired vibration and proprioception up to C6 level, from C6. And then spastic ataxic gait and Romberg's was positive. Here we'll localize, the structure localization is sensory level is C6, as there is a vibration sense impaired till C6. And the reflex level here we can take as the highest level because there is a brisk reflexes in the upper limb also. So C5, C6 can be taken. Then the motor level, as there is prominent upper limb involvement also there, we can take above C5, C6. And bowel bladder, it is a suprasacral infrapontine bladder. So whether it is a compressive or a non-compressive lesion, it is a compressive lesion because of the course, insidious onset, progressive course with a history of chronic neck pain and a late bladder involvement. Whether it is extramedullary or intramedullary, it is extramedullary as there is a well-defined sensory level with a late bladder involvement, predominant posterior column and corticospinal tract involved. The odd points here are the glove and stocking sensory pattern, which could be a peripheral neuropathy, and prominent small muscle wasting of hands. Here it is a false localizing sign due to the C8T1 root compression due to the vascular compromise. So it could be, it's here MRI has been taken, which showed in the sagittal image there is a central disc herniation at C5, C6 level, compressing the adjacent segment of the spinal cord, showing a focal area of T2 hyperintensity also. So this is cervical spondylotic myelopathy. It's the most common cause of myelopathy in adults more than 50 years. And in our case, it is compressive cervical myelopathy due to cervical spondylotic myelopathy at C5, C6 disc osteophyte complex with a C8 false localizing sign secondary to vascular compromise of the anterior spinal artery branch. So here the initial management is a cervical collar for neck immobilization, analgesic and other neuropathic pain medication, intensive physiotherapy for gait training and hand function exercise, bladder management using anticholinergics for urgency, and surgical compression is recommended due to the progressive myelopathy symptoms, significant cord compression with the T2 signal changes and sphincter involvement. The operative management, ma'am, cases hours and MRI is taken, and the management is taken from our case history, everything from our. Then management part is taken from this guideline. That patient stabilization, fusion of cervical discectomy with the fusion has been done, madam. That post. Yes, madam.
You can still take a test. Or if the patient
The operative management guidelines given post after disc fusion and decompression has been done, and there he's currently using cervical collar for immobilization and follow by.
what happened to the patient became better or consistent problem?
There is no further progression as in their notes. Next. Next.
What happened? And then it's not
Other cases are from journal. Other cases are from journal. Next case is a 58-year-old retired government officer with a history of CA prostate diagnosed 2 years ago, presented with a 6 weeks history of progressive neurological symptom, insidious onset, severe mid-thoracic pain, radiating to both sides of the chest for 2 months, aggravated by movement, coughing and lying down, with only partial relief from analgesics and a band-like sensation around the chest. He developed progressive bilateral lower limb weakness, difficulty in walking and requiring support for ambulation, along with ascending numbness and paresthesia starting from both feet and extending up to the level of umbilicus. And for past 10 days, he developed urinary hesitancy and urgency to occasional incontinence and retention. He also reported a weight loss of 8 kg over 3 months, fatigue and night pains, and no history of trauma, fever, or bowel incontinence. Here on examination, the patient is cachectic, localized vertebral tenderness over T5, T7 spinous process. Tone is increased and there is spastic paraparesis. Power in the upper limb was full. And lower limb, there is a grade 3/5 power with proximal more than distal weakness. And deep tendon reflex in upper limb was normal. Brisk in lower limb with sustained angle clonus and bilateral extensor plantar. And sensory examination showed a sensory level with impaired pinprick and temperature below T6 and below the level, and reduced vibration sense and proprioception also. With a spastic gait, there is no cranial nerve deficit or cerebellar signs. Here, localization, sensory. Yes, sir. Because the compression is from outside and the sacral fibers are placed more laterally. So the sensory symptoms will be sacral, thoracic, lumbar, thoracic and cervical. It will be an ascending symptoms. Yes, sir. And the sensory level is at T6 as we got a vibration and impaired pinprick temperature and reduced vibration below T6, and reflex level as it is consistent with a lesion above L1, as we got that there is a brisk DTR in the lower limb, and motor level is above L1 with a vertebral tenderness we got over T5 to T7 process. So here it could be a compressive, likely a compressive extradural lesion at T6 level. And an MRI has been taken which showed sagittal T2 showing a T7, T8 level. There is an extraosseous paravertebral epidural soft tissue tumor extension that causing significant narrowing of the thecal sac. And there is T2 hyperintensity also extending above this level to T6 and below this level up to T9. So these metastatic myelopathies, that is, this occurs in 5% of all cancer patients, and this accounts for around 50% of adult acute myelopathy. And the primary is usually from breast, lung, prostate, kidney, or myeloma. And the metastatic site is most commonly reported as thoracic vertebra, but it can occur to any site and maybe multiple also. And bone pain and tenderness are the common features, usually preceding the limb and autonomic dysfunction. So in the metastatic spinal cord compression, we have to suspect metastatic spinal cord compression in any patient with a non-malignancy presenting with a new onset back pain or an evolving neurological deficit, and the hematogenous spread via the Bateson venous plexus that seats the thoracic vertebral body. And the local tumor expansion will cause bony destruction and pathological fractures. And the epidural invasion also lead to mechanical compression of the spinal cord and thecal sac. So Diagnostic approach and treatment, as we discussed, initiate steroids before imaging if clinical suspicion is high, and obtain a whole spine MRI within 24 hours to confirm the diagnosis, define the level, extent of compression, and screen for any skip lesion, and assess for surgical candidacy. And radiotherapy, surgery followed by radiotherapy is the usual definite management. If in case of poor surgical candidacy, we can go with radiotherapy and otherwise palliative care. The next question is a 42-year-old male farmer present with 4 months history of progressive mid-back pain followed by 3 months history of bilateral lower limb weakness. He reports difficulty in walking with frequent falls over the last month. He also complains of numbness and tingling below the mid-chest level and urinary retention requiring catheterization for past 10 days. He had a history of contact with tuberculosis 3 years ago, but did not complete any screening, and no history of fever, cough, hemoptysis, or recent trauma. On examination, there is a kyphotic gibbous deformity at the mid-thoracic region and bilateral lower limb weakness, proximal 3/5 and distally 2/5, with pinprick and temperature is lost below T10. Deep tendon reflex in the upper limb is normal. In the lower limb, it is brisk and there is an absent lower abdominal reflex. So here the localization sensory level, as we got T10, there is a loss of pinprick and temperature, and reflex level is T10 or below, because upper limb reflexes are normal, lower limb reflexes are brisk, and there is a lower abdominal reflex also absent. And the motor level could be at T10, because lower limb bilateral spastic paraparesis, we got a sensory level at T10 and a gibbous set with kyphotic deformity at T10 to T12, and the autonomic bladder also. Here, this could be an extradural, extramedullary compressive myelopathy lesion likely at T10. And this gibbous at T10, T12 means that is a destruction or collapse of the vertebral bodies. That means the vertebral body pathology that lies outside the dura, and common cause in the background of contact with TB, it could be tuberculous spondylitis.
What is the style?
10.
You are telling everything at teacher. What did you point at teacher? Prodigal at teacher. Then tell me what is the technical of 8 and
L1. Spinal cord. L1.
You could elaborate that. We can know like picture of this. Then we will.
L1. So here the gibbous formation in the thoracolumbar lesion and T2-weighted MRI showing spinal tuberculosis at T10, T12, causing the destruction, collapse of vertebra and angulation of the vertebral column. Port spine with anterior epidural abscess or granulation tissue causing cord compression. Tuberculosis primarily it affects the vertebral body causing osteomyelitis. So the abscess or granulation tissue extends into the anterior epidural spaces, produce an extradural compression of the thecal sac and spinal cord. And in here, we can start ATT immediately and plan early surgical decompression or stabilization, and posterior approach is preferred. That is decompression with the pedicle screw fixation and fusion. And if there is a large anterior abscess, anterior compression with the grafting, and combined anterior and posterior approach in severe kyphosis, and we can continue ATT for 9 to 12 months with aggressive rehabilitation. These are the indications for surgery. Now we'll see the next case. This is an 85-year-old woman presented with 8 months history of chronic interscapular pain, worse on the left side. And over the last 3 months, she has developed tingling paresthesias and numbness, predominantly in the left lower limb, with milder symptoms in the right leg. And she complains of mild unsteadiness while walking, particularly on uneven surface, but has no bladder or bowel complaints. On examination, upper limbs were normal. Bilateral lower limbs, left side 4 by 5 power and right side 4 plus by 5 power. There was an asymmetry with sensory pinprick and temperature sensation reduced below T6 level, and it was more marked on the left side with vibration and joint position sense was mildly impaired bilaterally. And the reflexes in the upper limbs were normal. Lower limb, it was brisk more on the left side with left side plantar extensor, right side was equivocal. There was a mild spastic gait with left side circumduction gait. No spinal tenderness, deformity or root signs in the upper limb. So here, as the upper limbs are completely spared, again the lesion will be below C8T1 and the lower limbs are involved, so the lesion is above L1 and the motor level is likely at the thoracic region. And we have got from the history, there is an interscapular pain which corresponds to T4 dermatome, but on examination we got a sensory level at T6. Here the sensory level usually 1 to 2 segment below the actual cord compression site. So level. So this is a slowly chronic progressive symptom over months with asymmetric involvement, as there is more symptoms on the left side than right. Usually it is seen in extramedullary lesion that displays and the compressor cord from one side, and predominant sensory symptom with mild motor weakness is classic for this extramedullary lesion. They compress the cord externally rather than from intramedullary lesions. So there is no root pain in radicular. This is because of the asymmetry, it is intradural. Sir. And the preserved bladder bowel function suggests that the lesion is not yet causing the central cord compression. So this is a case of intradural extramedullary compressive myelopathy because of the pain. One is chronic unilateral pain, marked asymmetry and brown sequoia-like pattern with slow progression and absence of any vertebral sign. So this was a MRI that was showing a intradural extramedullary mass at the T4, T5 level and displacing the spinal cord to the right, as we can see in the axial section. And an axial CT image shows dense ossification of the mass also. So in meningioma, the characteristic MRI finding is it is in the T2 weighted, it is usually near iso-indents to the spinal cord, and T1 will have iso to hypo-indents, and contrast will show a homogeneous enhancement of the mass, and axial also showing the same. So the characteristic MRI appearance is T1 iso to hypo-indents, T2 iso to mildly hyper-indents, and a homogeneous indents contrast enhancement with a dural tail sign may be present. CT is useful when the tumor appears very hypo-indents or to detect any calcification or ossification. And the definite treatment is surgical excision, laminectomy or hemilaminectomy with microsurgical excision, and excision of the dural attachment also. And as we discussed, intradural and extradural, in intramedullary, the common tumors are ependymoma, astrocytoma, hemangioblastoma or metastasis. And the common intramedullary metastasis primaries are lung cancer, breast cancer and melanoma. The intradural extramedullary tumors are this schwannoma, neurofibroma, meningiomas. And extradural extramedullary tumors are bone metastasis, chordomas and sarcomas.
First case, so when she said bowel stopping son, bowel stopping sensory, so no cervical. Generally, when peripheral rocking, which starts first and then starts from the lower as opposed to in a cervical, you can dial both together where you have pounds of together or down followed by stop. Both parallels. So down and stop on a perfect. Also have a drop sensitivity. They never cervical cord involvement, but you can have a sensitivity it's only that is well known. Not have a sensitivity exactly that's what. Sensory can be made cervical with the sensory. Sensory is off the load. Sensory cannot be directly giving to gives you very enough. You have given able to
If you should understand clearly how to final level and that you need to reach, and you just compensate with it. Equal. The fellow very clearly asked, we can outline, but the second and say exactly what happened.
Better on the stop. Ready? For the next time.
Upper cervical.
That is the most important thing that people
Upper cervical will corresponds to the same level, whereas C7, T8, the lower cervical, it will be one level higher. And upper thoracic up to D6, it will be 2 levels higher. And D7, D8, D9 will be 3 levels higher. And D10 will corresponds to L1. L1, L2. The vertebral segment will be 2 levels higher. If it is D6, then it will be at D6 spinal segment, it will be D4 vertebral.
How common is that? How common all the time.
Anterior spinal artery, usually they will have an acute. Anterior spinal cord syndrome, in anterior spinal artery infarct, usually it will have an acute presentation. They will usually present with the acute flaccid quadriparesis with the, depends on the level, flaccid quadriparesis with the loss of pain and temperature with preserved joint position and vibration sense. In addition, there will be bladder involvement because of the lateral and the anterior 2/3 of the spinal cord is involved. So bladder involvement will also be there in the early stage. Acute presentation. It could be in spinal shock.
For the secondary vascular movement,
Because of the watershed territory, there will be mainly in the between the upper thoracic and lower thoracic.
that is what it is. Can there be a compromise of arterial drainage, or can there be a venous drainage?
Sir, because of the in compressive lesions, because of the compression, it can cause blockage of the venous drainage, and it can cause secondary vascular compromise, or it can directly compress the anterior spinal artery and can also cause the at a lower level also there will be vascular compromise.
Six-year-old man or fisherman goes to the hunting itself. It's a paralysis of the limbs. I want to get association. Says there's an underlying. But still, when you get had to pull up a lot of weight and he actually slipped and fell over a tire instead. And kind of paralysis. All reflexes are sensations and either sensory level
sparing
and it is finally. So I gave you a display. This happened when you woke up in the morning. 356. Doesn't have any. Here's past history of all the previous days.
Yes.
Like, so this is the fibrocartilage that presents with the anterior spinal artery like presentation. Because it's a T6 present. Any anterior spinal artery T6 or upper. So when you have a T6 kind of thoracic kind of upper, the young individual does not have any body. It all with atherosclerosis spine. And this spinal artery actually a atherosclerosis. This says T6 and all very unlike atherosclerosis should grow more